Now, when you look at a club foot, you have to understand there are two different ways we can classify club feet. The first way is looking at what is the etiology of the club foot, and secondly, where does it lie in the treatment spectrum. All right. So, as term of etiology, anyone has any idea how do we classify club feet? So, one is an idiopathic club foot, and the other one is a secondary club foot. Okay. So, remember that the word idiopathic means that you have ruled out all other causes for a clubfoot, because clubfoot can occur because of several different causes. And we always say that idiopathic means the child has a pathology and the doctor is an idiot. So remember that don't use the word idiopathic unless you're absolutely certain that the child does not have a reason for the clubfoot. Okay? So which means that we should know what the reasons for club feet are. So if we look at what are the secondary causes for clubfoot, there are just two broad classifications. Either they can be neuropathic or they can be syndromic. Okay, so if you look at neuropathic means there's a muscle imbalance. That means the inverters and the plantar flexors are stronger than the everters and the dorsiflex. That's where the foot has gone into a 𝐬𝐤𝐂𝐤𝐈 deformity. So really we should not be calling them as CTEV. We should not be calling them as clubfoot. We should be calling them as 𝐬𝐤𝐂𝐤𝐈 deformities, because that's what they actually are. So anyone knows what are the causes for a neuropathic clubfoot? Any neuromuscular condition like spina bifida. So if you have a lesion in your back, if you have a child who's born with a myelomeningocele where there is a herniation of the thecal sac, then I'm not using the slide, so that's okay. So that is the cause for neuropathic clubfoot. Then if the child has poliomyelitis, if the child has cerebral palsy, of course then a child will not be born with that type of clubfoot. That's why it's acquired. It's secondary. So the two common causes, as we said, would be spina bifida, cerebral palsy, poliomyelitis, any neuromuscular condition where there's an imbalance between the inverters and everters, dorsiflexors and plantiflexors. So that's the first big group of secondary, that is neuropathic. The second is syndromic. Under syndromes, any idea? What are the different syndromes that can cause a clubfoot? Yeah? Say something. Yeah? Arthrogryposis, correct? Arthrogryposis. What is arthrogryposis? Where the child is born with multiple congenital contractures. And arthrogryposis is just a terminology. Remember that under arthrogryposis there are 150 different conditions which can present like this. The typical one is what we call 𝐬𝐤𝐈. 𝐬𝐤𝐈, where you have a child, very typical features where you have a specific positioning of the hands, the feet. You'll have joints which are very restricted in range of motion. You have tense, shiny skin. You have absence of skin creases. That's the most severe form of arthrogryposis, which is called as 𝐬𝐤𝐈. Lack of formation of good muscle, where muscle is replaced by fibrous tissue. And then you have milder versions of that, which is called distal arthrogryposis, and so many other varieties within that framework of arthrogryposis. But remember, that's the biggest condition under syndromic. Anyone knows any other syndrome? This is a common question asked in the exam. So those of you exam going, sometimes you should know this, because examiners love to ask this. What are the different types of syndromes that are associated with a clubfoot? So some common ones: Freeman-Sheldon syndrome, dystrophic dwarfism, multiple constriction rings, which is Streeter's dysplasia. So these are all different syndromes that are associated with a clubfoot. All right. So this is very simple. So you have two types basically: idiopathic, secondary. You have to rule out all causes before you say it's idiopathic. Under secondary, what do you have? You have neuropathic and syndromic. Under neuropathic, commonest one is spina bifida or myelomeningocele as we call it. It can also include cerebral palsy, poliomyelitis, any neuromuscular condition which is causing an imbalance between the different muscle groups. And under syndromic, the biggest one is arthrogryposis, which has multiple forms, the most severe form being 𝐬𝐤𝐈, and then other syndromes which I have just named to you. Alright, so that's a very simple way to classify the spectrum of clubfoot depending upon the etiology. And then we have some other terminology which you all will hear very frequently, and again examiners love to ask that. What is a residual clubfoot? What is a recurrent clubfoot? These are just English words, there's no medical terminology really behind it. So when we say residual, what we mean sometimes is that the patient has had a treatment, but there's some deformity which is remaining. Okay? Recurrence means that the foot was fully corrected by whatever method, whether it's by conservative or by surgical methods, but some or part of the deformity has returned back, which needs further treatment. So there's a mild crease coming here and there, that's not called a recurrence. So there's a return of a deformity which requires treatment is the definition for a recurrent clubfoot. And then finally we have this group which Matthew has spoken to you about, which is the older child, which we at one time used to call neglected, and rightfully now we should avoid using that term neglect, because really speaking that's the wrong word to use, because that implies blame on someone. So either we call it untreated clubfoot or we call it late presenting clubfoot, because untreated may not be the right word again. Some of these children have had treatment, but they have not had the right treatment. So therefore we use the word delayed presenting or untreated clubfoot. Okay, so this in a nutshell is basically the spectrum of clubfoot deformity. I don't think there's anything really more. If there's anything on the slides, we'll just run through them. Is this moving?
Reverse one.
Okay.
Yeah.
All right. So that's what we are saying. So that's idiopathic clubfoot, exactly what I told you. So the secondary cause is neuropathic syndromic. So here you have a child where very typically you can see that myelomeningocele in the back. Sometimes it is very obvious like this, sometimes it is not. So sometimes what are the other features of spina bifida? You can see a hairy patch, right? You can see a hemangioma. You can see a dermal sinus which goes right down into the spinal cord. So these are all manifestations of myelomeningocele. That's very obvious one. And this is a spinal dysraphism where, as you have said, this is fawn's beard or a hairy patch. Here you can see a child, when you see an ulcer like this, you know obviously that the sensations are lost. So the protective sensations of pain are lost. So whenever you see a foot like this, you must always inspect the back. Always check for overt signs of spina bifida or signs which are not so obvious, like as we showed you. But don't miss this and call this idiopathic clubfoot. Okay? So that's okay. This is one we forgot to talk about. This is an entity which we have become more and more familiar with nowadays, called an atypical clubfoot. And there's still a little controversy in literature. What really is an atypical clubfoot? If you see the presentation that came out from Ponseti and a group of people who identified this for the first time, they said it's more of a condition which is caused by us. So that means it is a problem which is caused by doctors because we don't apply the plaster the right way. So the plaster tends to slip. These are feet which are generally in fatter children. So therefore the heel gets squashed against the back of the plaster, and there's a cock-up deformity and the plantaris deformity of the entire forefoot and a short first metatarsal. But you can also find some of these children de novo. So it's not always caused because of us and our manipulation and plastering, but sometimes you have some of the children with arthrogryposis who present de novo with an atypical clubfoot. There's a different method of how to correct this kind of a foot. Then of course we talked of a recurrent clubfoot, we talked of an untreated clubfoot. Okay, and here's a child with a recurrence. Okay, so some quick case examples before we wind up this talk. So now that we have spoken about this, some response from you all. How would you classify this foot? What kind of a foot is this? Loudly, loudly, loudly. Syndromic, correct. But what syndrome? Streeter's dysplasia, excellent. So you see this constriction ring, all right. Sometimes it can be very thick. Sometimes it can cause even edema of the foot. And sometimes it needs a release before we actually do the casting. So this is a very typical case of Streeter's dysplasia. This is something which we must always pick up, all right? And this is when we talk about the scoring systems, you'll realize that we have different scores that we use, and the commonest one we use is called the Pirani score. But the Pirani score is more of a morphological score. It tells us about the shape of the foot and the mobility of the foot, but does not tell us about muscle action. And that's where the other score, which is called the De Begleau score, is more useful because it also checks muscle action. So whenever you see a club foot, when we talk about that in the assessment, we'll talk about how to stimulate the foot and check for muscle movements. And this is a very important sign where when you stimulate the foot, you'll find that the toes are moving, but the first toe or some of the toes don't extend properly. So this is called the drop toe sign, which was highlighted by Stephen Frick. And this is an important sign to tell us that there's a neuropathic element to this foot. Some of them are very obvious spina bifida, or they have some signs of a neuropathy. Some of them don't have that. But we must identify this because this is an important sign that we should not miss out on. Okay. So obviously this is a syndrome because there's something going on not only with the feet, but you can see that there are bilateral knee flexion deformities, there's probably bilateral hip dislocations, a very typical posturing of the upper limb. So what would this diagnosis be? Loudly. Yeah? No wrong answers, as I said, only wrong questions. So you're never going to be wrong. Yeah? arthrogryposis. Yes, so this is not the typical 𝐬𝐸 because here you can see that the joints are not so bad. There's not, there's okay creases. So this is a different variety of arthrogryposis, probably a distal arthrogryposis, which is not the severe 𝐬𝐸. Okay. Here's a child, as you can see, along with a foot deformity, the child also has a knee dislocation. Okay. Okay. Anyone take us for this? So here you can see the toes are not well formed, the multiple sort of nubbins in the toe. This is also again a manifestation of Streeter's dysplasia. All right. What about this one? So here, if you look at the foot appears to be turned in, but that's not really true, right? If you look at the foot by itself, the foot is otherwise normal. It's the whole leg which looks bowed. So there's obviously something going on with the leg here. So anyone has any clue? Very good. So this is a tibial hemimelia, all right, because you can see the fibula is prominent and the leg is bowed, but the foot is actually not very bad. So here we should not be treating the foot. We should look in terms of what is the tibial hemimelia. There's an absence of the tibia and how we can manage that. And that you can see on the X-ray here very nicely. You can see that the fibula is so prominent and the tibia is looking to be absent. Sometimes if you do an ultrasound or an MRI, you might find that there's some little anlag of the tibia which is present. Okay, anyone for this one? So you can see there's some extra toes. So this is a clubfoot along with a preaxial polydactyly. And many of these have what we call a bracket epiphysis, where the epiphysis is D-shaped of the first metatarsal. So these are all different types of anomalies that can exist with a clubfoot. Okay, this one, again you can see there's some syndactyly occurring here. So these are sort of complex club feet. So remember that we are looking at an entire spectrum here. So don't ever presume that when you see a child with a clubfoot, it's always idiopathic. In fact, the first thing that we should be doing is to rule out that there are other causes. And only when we are sure that there's no syndrome, there's no neuropathy, then only we can say this is an idiopathic clubfoot. Okay. So this is a child with hypertelorism. So obviously this is very syndromic, right? And this is just the final one to show you that these are all children who have had clubfoot, which have been treated. They are all happy, no disability. This is what we want to achieve when we treat clubfoot, and that's what is going to be the whole focus of the training that we're doing today. So thank you very much for your attention. Any questions?